So I'm going to hand you over now to Middlesbrough, to Jennifer and Claire, and over to you.
Hello, thank you. It's been lovely listening to everybody so far. Hello to everyone, and thank you for inviting us to the presentation today. There's myself, Claire Thompson, and my colleague Jennifer Williams. We're slightly anxious and very humbled actually to be asked to do the presentation today, because we're not researchers or academics, just experienced clinicians that have a lot of experience working in health and social care for many years. We often don't think that we're doing anything particularly amazing or extraordinary, but we do wonder sometimes when we hear the difficulties and struggles that other areas can experience. So we just wanted to share with you today a snapshot of what we do and why we think that it works quite well for us here in Middlesbrough. Sorry, I'm just trying to share the screen and it's not working. Oh, is this working? That's fine. So an introduction to the Children with Disabilities service. So both myself and Jennifer are employed by Middlesbrough Council. So we work within social care, within children's services. So we don't have a specific direct therapeutic role. We accept referrals for any child aged 0 to 18 years with a disability from parents, carers and professional colleagues if there's an impact on daily living skills at home. The children and the young people who may get referred to our service can vary from having a physical disability, a learning disability, or a neurodevelopmental disorder such as autism. Occasionally we do have referrals for children with mental health issues, such as very severe depression, who may be at risk of self-harm. So looking at our referrals, there's been a steady increase in the demand for the service over the past couple of years. Jennifer started in 2014 and I started in 2016 following the retirement of a previous OT, and we equate to 1.3 whole-time equivalents. The OT service as a whole uses a caseload weighting tool, and in paediatrics many of our cases are in the highest level 7 category, so mainly involving moving and handling and disabled facilities grants. This demonstrates that the complexity of paediatric cases is often high, with the intervention being very lengthy and intense, but can often achieve great outcomes for the child. For example, an extension, our involvement could potentially be up to 18 months, depending on their complexity. So looking at professional supervision, we're really very lucky here in Middlesbrough. We sit clinically within the Children with Disabilities service. This comprises of social workers, occupational therapists, short breaks service, and also the home support service. It's really very positive because overall the team has a great understanding of everybody's role and what we can support with. We're often seen as a real resource within the team for advice and signposting, and we benefit from the greater understanding of the child and the family. Here in Middlesbrough, often a lot of our cases are very socially complex, not necessarily safeguarding, but often a lot of additional complicating factors. We get our professional supervision from an occupational therapy team manager from adult services, and we follow all the same occupational therapy processes and systems that are in place for our adult colleagues and links to the Stay Put agency as well. We get quarterly supervision and service catch-up with our Children with Disabilities assistant team manager, so that's a social worker, and immediate access to social workers and managers for any safeguarding issues or concerns, and that's really important to us working in children's services. Our OT management and supervision is essential, and we're very lucky to have occupational therapists and children with disability service managers who value us as experienced senior clinicians and appreciate our contribution to the service as a whole, and who trust our judgments and clinical reasoning. They do often challenge us, and rightly so, and often work together to create useful suggestions and be creative when needed. And overall, this makes our job a whole lot easier. So looking at the occupational therapy assessment, we're carrying out assessment with the child and family at home to identify the needs. We may invite another colleagues on this visit. It may be social workers, our health colleagues, the community paediatric OTs, particularly if it's a very complex case. We often have common referral themes, as you can see on the slide, and it's quite rare that we'd only have one of those come in as a referral. Often it's a combination of all of those. And we're often looking at identifying short and long-term needs, and we may issue equipment while exploring other more suitable long-term options. So looking at our occupational therapy involvement, the aims of our intervention will be to enable the child to be independent and safe as possible, depending on their disability, and to enable carers to care and manage the complex needs of their child in all activities of daily living. Intervention may be advice and information and signposting, the provision of specialist equipment, minor works and housing adaptations. We work closely with local housing associations if rehousing is considered the best solution to meet long-term needs, and we don't always immediately jump to adaptations. We'll also work very closely with other health, education, social care colleagues involved in the child's care, so it's very much a multidisciplinary team approach. So looking at working with parents and carers, we feel working in paediatrics that it's very important to establish a relationship with the family and child and to gain their trust and really to reassure them that you're there to support them as necessary and not create barriers for them. It's important to establish the parents' understanding of the child's long-term needs and whether they are ready to work on a long-term solution with you. It can be quite difficult when you're getting involved when the child is very small, particularly when the family might still be grieving for the child that they don't have, and the child can be quite small and still easy to handle, and equipment starting to get more different and more specialist, and then obviously we turn up. So I'd just like to hand you over to my colleague Jennifer Williams, who will do the next part of the presentation.
Hi, so the DFG referral, we find that can depend on age and diagnosis, the child's future potential. Sometimes it's too soon to start anything too early, if the child's making progress, even if slow, and that can be a bit of a balancing act sometimes. But we have started a DFG when the child's been about 14, 18 months, because it's been very, very, very clear. The parents were on board, there's been multiple complexities for the child, significant moving and handling even at that young age. So it's felt right to start off the DFG. And the same criteria for the referral as for any other case: permanent and substantial disability, access to essential activities of daily living, identified works to be essential rather than desirable, necessary and appropriate, and obviously it's not means tested. And this can apply, this kind of whole feeling can apply to even a rehousing application sometimes. Some parents want to start too soon, and actually we just need to hang back a little bit. But obviously it all comes down to the parental acceptance and understanding. So as OTs, I think what we do well here in Middlesbrough is that we always encourage parents to look to the long term. I think that's been our benefit of working, with older children and with adult services, and having just been around for a while. We always try to take into account growth and the child's potential long-term needs, trying to consider the simplest and the most cost-effective way. It's not always an adaptation. We kind of probably go through the same kind of clinical reasoning process that you might do with adults. Equipment, can you get upstairs using a stair lift, through floor lift, extension, etc., and that you're communicating that to the family, and you're sharing your clinical reasoning and establishing those boundaries. We will always discuss the case and supervision, and then through to DFG panel if we're making a DFG referral, particularly for complex adaptation. And I think a lot of it, the challenge is around this kind of equipment versus design, or probably as our tech officers say, why we're sometimes a bit difficult. We always want to encourage good practice from an early age. We've all got those parents who are still handling kids when they're way, far too heavy and long to be moving and handling them. We're trying to ease complex care routines. Most of our children have really complex additional health needs, and care and medical routines take up a massive part of their day. And we're trying to strip out some of those layers of complexity, and it can have such a positive impact. Trying to be aware of the needs of the child, what exactly is involved, how will any equipment and adaptation impact or be impacted on. Claire's just recently spent a lot of time with our nursing colleagues for a child who's on a really complex oxygen routine. Trying to think about circulation space that will be required. Is there a need for double-sided care? Will there be a need in the future for double-sided care? Do we need to consider room size for equipment features if equipment's going to be tilt in space? And we need to consider growth. And although it's not part of the DFG legislation, we try to take into account, at least in some of our clinical reasoning and thought process, storage. Families are getting 3 months of supplies of nappies, medical equipment, feeding equipment, oxygen, wheelchair, therapeutic equipment, and it all needs to go somewhere. We try to take into account the size and the needs of the family, even if it's a first child. It's sometimes a bit cheeky to say to a couple, what are your plans for the future? Especially if you're looking at taking away living space or dining space, etc. And it's not that we're lax or that we're soft, we're just trying to make sure that we can really clinically justify those extreme cases. So trying to design for the longer term, I suppose some recent projects have included ensuring we've got a larger bathroom, a larger shower area, often our tech office's big bugbear, to make sure that we can cater for growth and age, and a lot of the kids have got complex movements, complex tone. So we tried to make sure we've had a good sized bathroom, so we can put in something like that 1900mm shower trolley and get that longevity. It's height adjustable, it's got drop down sides, it's on casters, and we try to go for the largest size, and it gives us a height adjustable platform in that area for all self-care tasks. You can hoist onto the trolley, it reduces moving and handling, it keeps those self-care activities potentially to one area. Sleep systems on beds, which are great for your postural management, but they just add another layer of complexity for moving and handling. And if you're rolling people to put them into sling, rolling the child to put a sling on and off. Lots of our children have really complex bowel habits, or lots of bowel issues because of medication and seizures. And if you're having to do all that personal care on the bed, it can just make it really difficult. So that we found this to be a really useful long-term solution for those very physically disabled children. Hoist onto the trolley, undress, shower, dry and dress again, all in one area, and you're helping to strip out some of the moving and handling. And it's giving us longevity. And as the OTs out there will know, there's not a great deal of equipment. Choice is quite limited. It's not all great, particularly for our children who've got increased tone, extensive spasms, postural changes. It's not always very comfortable for those kids. And we've done a little bit of training for our technical colleagues around this, because I think sometimes they didn't always understand why we were looking for this larger shower area, why we were always maybe asking for a shower trolley when their experience previously had been to use shower seats. But we were finding...
Jennifer, it's just 1 minute left.
All right, okay.
Thank you.
No, it's all right. Just trying to get the next slide. Oh, I've gone that wrong way. Oh, I've gone too far now. Right, so sorry, the slides are going. I'll just keep talking. Safety advice. Over the last couple of years, we've had a huge increase in numbers for safety advice for in and around the home. It was a common theme, talking to colleagues, a common theme across all our neighbouring boroughs. We developed, on the back of that, we developed a safety advice booklet, which was just full of suggestions and tips where to get help and support, to try to give to parents initially, but perhaps before a referral comes in to us. just to see if there's things on the market that they could use in general before it had to become a specialist referral into our service. Also to highlight that equipment and minor works doesn't always replace the need for good supervision and parenting, and that the child will often still need a high level of care and support within the home and the garden, despite any measures we might put in place. We found a couple of training courses that we can give details on that helped us with some of the safety advice, and obviously good links in with our local CAMs and LD CAMs for advice and support, and that multidisciplinary working around those complex children, particularly if we're having to make potentially restrictive practice decisions and provision which we don't always want to make. And they can be tricky cases. Behaviours are often well established before we become involved. And just a little bit about learning from experience. I suppose we've both been around for a long time, and we've had our fingers burnt. We've inherited kids that have got cases that have had no longevity, old adaptations that have had no longevity, not necessarily as a result of changing need in the child, but the size of the original adaptation and growth and larger equipment provision, and that'll have been around baths, through floor lifts, access. In Middlesbrough, we've got a lot of terraced houses, so they might have done an adaptation on the ground floor of a terraced house that will have suited the child when they were 5 or 6, but now they're 13, 14, 15, we're really struggling. And having the confidence to say no earlier, I think that probably comes with experience and confidence, and confidence that our managers will back us up, but maybe saying no earlier. And what works well for us in Middlesbrough, good assessment and clinical reasoning. We're really clear with the child and the families what the child's and family's needs are, and we're really good at communicating that and what we're trying to achieve through the provision. And we've got excellent joint working between us as OTs and our staying put agency, where our technical colleagues sit, who administer the grant and provide the technical backup. Lots of experience between us and our technical officers, and that we're all working for these common goals with the family, and we're not too scared to discuss and seek advice and guidance and brainstorm, and I think that's been one of the hardest things we found during the pandemic, is our isolation from each other. We've got good supervision. As Claire mentioned, it challenges us, but they're willing to listen, and the support enable us to do what we do and enable us to be creative as well, and that we've got this willingness to think outside the box.
15 minutes now.
Okay, and I think that we're very clear and explicit with families about what we can and can't do. And also think that our staying put agency and that whole DFG process is in-house in the council. Obviously, we've got the benefit of it's a smaller single authority, so it's been easy to create those networks. And tight project management and communication throughout the whole project, including between the OT, the technical officer, the family and the contractor, including pre-start building meeting and minutes and things. I think that's it. Could probably talk for much longer, but I think time's against us.
Thank you. That's lovely. Jennifer, can we just, is it possible just to, or maybe both of you, to answer some questions?
Mm-hmm.
I know that someone's asked about the email address, and the email address is now up. Someone said the risk booklet, is it possible to have a copy?
The safety booklet is on our local offer for Middlesbrough Council. So if you searched up Middlesbrough Council local offer and occupational therapy service, children with disabilities team, it's loaded up onto that local offer.
Lovely. Also, Claire, what workload waiting tool do you use?
It was a tool that I think was devised before I came into the service from our adult colleagues. I think it was a social work tool. Undergoing a service review, so it was evaluating the work and looking at different levels of interventions, so it's not an OT tool as such.
Okay, thank you very much, Jennifer and Claire, and telling us about the paediatric Middlesbrough service. Lovely, thank you very much. So we're going to go on now, and I just wanted to say thank you to all our presenters, a really large thank you, thank you, thank you. And judging from the number of people that are actually on the chat at the moment, I think it's over 300 at the moment, 500 people registered, but thank you, thank you, thank you.